You're listening to the Knowledge Archives podcast. Welcome to the Knowledge Archives podcast. We're a group of students on a mission to learn from as many different disciplines of knowledge as possible. I'm your host, Madhav Malhotra, and today I'm pleased to be joined by Dr. Ben Handel, Associate Professor of Economics at the University of California Berkeley in the US. Dr. Handel's research focuses on analyzing healthcare markets from the lens of behavioral economics, especially when considering the organization of the insurance market. I'm very excited to learn more about the workings of this specialized application of economics today. So thank you for joining me today. I really appreciate you taking the time, and I'm very excited to learn more about your work. And to start off, I'd just love to hear a little bit more about your story, who you are, what you're working on, and how you got started here.
Sure. Thanks, Madhav. My name is Ben Handel, and I'm an associate professor of economics at UC Berkeley in California. And my main areas of research are health economics, behavioral economics, and industrial organization. So I really kind of came to these areas during my PhD, which is I finished in 2010 at Northwestern, and really kind of came from two different perspectives to these topics. From a perspective of health economics, it really just became a topic I was more and more interested in during my PhD because people were starting to talk a lot about health reform in the context of the Affordable Care Act, which was a big healthcare policy reform that was passed in 2010. And in my work, I had always kind of sought to work on things that I found to be impactful. And this was clearly an area that kind of drew me in. Then I gained access to some really interesting data sets that allowed me to actually study these things in practice empirically. And that was kind of the thing that really helped pull me in and move from kind of being just conceptually interested in this area to actually working on it. Now, behavioral economics, that's something that I've always been interested in, really since starting to be interested in economics, which goes way back even further. And part of the reason for that is that most classical economics and economics as it's been taught for a long time, it really is based on kind of a foundation that consumers are rational and firms are rational, and they're always going to take the actions that are in their best interest. What behavioral economics does is it tries to move away from that and say, well, do consumers make mistakes? Why do they make mistakes? And what are the implications of those mistakes? And so combining that with health economics, where there's, as we'll get into, there's kind of many, many people making mistakes in many different contexts. It was kind of a nice combination.
Mm-hmm. And I know when I was reading through some of your recent research papers, about half of the abstracts kind of hint at for a long time that in the market of healthcare, whether it be insurance or something else, oftentimes consumers make suboptimal decisions. Now, for, say, people who haven't dug as much into the industry and don't know why this is the case, why does this happen?
Yeah, well, that's both in some ways an easy question and in some ways a very hard question. So I'll start with the easy part. The easy part, I think, is just if you think about healthcare decisions being made in your day-to-day life, I think most people will pretty easily start to understand why consumers are often coming at this kind of from a disadvantaged perspective or from a difficult perspective. So, and this may be different in the US relative to other countries around the world. But in the US, for example, take one example of seniors, so people over 65 who choose health insurance coverage in the United States. So there's a prescription drug program called Medicare Part D, where privatized insurers sell insurance to seniors. And the way this market is set up, seniors typically have a choice of roughly 30 to 40 options. So what does this mean? When seniors go to choose health insurance, which is covering very important prescription drugs for them, they have 30 to 40 options with all of these different features. So what's the premium, which is the amount you pay up front? What's the deductible, which is the amount you pay during the year before the insurer starts to pay money? What is the co-insurance rate? What is the out-of-pocket maximum? What is the copay? What is on the formulary? And part of the reason I'm actually not defining all of these things is that the audience, but also most seniors, have no idea what these things mean, and they're making important decisions. Now, when you layer on top of that the fact that seniors have actually a very difficult time, not all of them, but some of them, using technology and understanding what these things are, that's kind of a perfect brew for just people making lots and lots and lots of mistakes. That was in the insurance context. I'll very quickly also touch on the actual context of healthcare, of actually getting healthcare, where there's less rigorous evidence for this out there, but it seems pretty clear that because of the many difficulties when you're choosing a medical treatment from a complex set of treatments, there are some research articles out there that show that consumers are often either making mistakes or not very well informed in terms of the actual care that they're receiving. And the more autonomy and independence consumers have in that process, in some ways, the harder it is for them.
Mm-hmm. And when we consider the root cause of this, I know you were talking about the complexity of the market and all of the options for consumers, and that definitely seems to be one confounding factor. Do you think that there are other issues at play regarding how there might be regulatory policies involved, how information is sent out to consumers? Because in Canada, things are a little bit different, but not quite as bad.
Yeah, I mean, I think in Canada, the fact that things are single payer helps a lot, because a lot of the complexity in the US is on the insurance side. Probably you have similar complexities in terms of receiving care and choosing actual medical treatments in Canada as well as in the US. But on the insurance side, there's been a lot of work on this, both from the private sector to help people as well as from the government, and often those two working in concert with one another. And there's two types of interventions that I would think of. One is what I would call kind of relying more on consumer autonomy class of interventions. And so those kind of interventions are things like giving consumers information about the options, giving them information about their own health risk, giving them information about how their own risk meshes with kind of the different features of the options if we want to become more sophisticated. There's also things which are more trying to move better options to the top, for example, of a web display. So kind of steering consumers broadly in a certain direction towards ostensibly better options. Those options are employed pretty regularly, though the extent to which they're working, it doesn't seem like they're necessarily working that well. And part of the reason why is that sometimes these programs aren't targeted enough to a given individual or kind of sophisticated enough. Now, the flip side, another kind of intervention that I've kind of done some research on are interventions that I think of as more paternalistic interventions. And so paternalism here means interventions where the government or the firm or a regulator is really kind of more aggressively steering you as a consumer towards something that they think is a better option for you. And so in this case, for example, that could mean I, as a regulator, have an algorithm that takes in data for you, takes in data on the options available in the insurance market, and then implements a targeted default option where I say, well, I'm going to enroll you in this plan, which I think is the best one for you, unless you make an active decision to change it. And there's research showing, not just in healthcare, but also in things like retirement savings, that these kinds of default options are very powerful in terms of steering behavior in these kinds of situations. So there's these kind of more active interventions where consumers are really taking things into their own hands. And then there's more an intervention where you say, well, I'm not an expert on this as a consumer. Why don't you just make a choice for me or help me, steer me towards the right choice? And these things have a lot of intricacies and trade-offs involved, but both are kind of implemented to varying degrees.
Mm-hmm. And I know how you were talking about behavioral economics. It's just like we fundamentally, when we start to think of the incentives of the different stakeholders involved, right from introductory economics, like I'm taking, people will tell us about all of the conflicting incentives, about informational asymmetries and all the other fancy words. But if we were able to distill those down into the decisions actually being made and the incentives of what the different stakeholders are trying to accomplish, where do we see some kinds of conflicting incentives sometimes between the different stakeholders? And what happens when we, say, try to implement a policy like putting in some kind of new government information program or default program, but we haven't considered the incentives right? It would be great to hear about any real world case studies there.
Yeah, that's a really good question, and not surprisingly to you, I'm guessing, and probably to many out there, there's many conflicting incentives and many conflicting kind of sets of agents in this market. So I would say one major source of conflict is between insurers and consumers, where insurers, their role is basically to take the risk that consumers face in their expected health spending. They basically buy that risk from consumers, and consumers pay a premium to get this risk. Now, the insurance sector in the US is pretty competitive in the sense that there's quite a few firms in the market. But because consumers often lack great information on these options, what happens is that, especially once you enroll in an insurer to begin with, then a lot of times insurers can make more money from consumers. And this can be either by pushing more costs onto the consumers slowly but surely, restricting the doctors that they can see kind of slowly but surely. And so this is a direct conflict of incentives where, in some sense, the more consumers spend on behalf of the insurer, the worse it is for the insurer. But probably the better it is for the consumer, right? And so that's really a case where the incentives are kind of directly in opposition to one another. And because of kind of informational issues and behavioral economics issues, insurers are often doing things like trying to sneak in kind of different financial features or sneak in restrictions on doctors you can see or restrictions on services you can get. And that's where you definitely see these things coming together. Now, a broader issue in insurance markets is what's called adverse selection, where if you have sicker consumers and they select into insurance options, as an insurer, that's generally bad for you because you're generally paying more for these sicker consumers. And so insurers also have these incentives to basically steer sicker consumers away from their product and suck in healthy consumers, whether this is accomplished through advertising or through kind of making your services less attractive to sicker consumers and more attractive to healthier consumers. And that's a case where it's not only an opposition between insurers and consumers, but there's really issues where insurers' incentives are directly in opposition to one another. And in a typical product market, that's usually the case through pricing, where you're basically trying to compete with other firms in order to win customers. Here in healthcare and health insurance, it's a little more subtle, where you're competing with insurers not just to attract more customers, but to attract a very specific kind of customers who are healthy consumers. There's many more instances of this in healthcare markets, but I think those are some kind of core examples.
Yeah. And I know some of your recent papers focus on the role of technology being integrated into these healthcare markets, not just in a way of better types of medical technologies being used, but also kind of directly in a way of the economic markets in terms of perhaps AI being used to make decisions instead of consumers. Could you explain a little bit about some of the rationale behind this in terms of the benefits that we see we can have when we automate the decisions and considering all of the types of information that you were talking about before? And then in terms of the real life implementation of this, have we seen any major case studies of this occurring so far?
Yeah, it's a really good question. And as with many parts of the economy, AI is being integrated in myriad ways into the healthcare sector. And so I'll give two examples. In the research that I've done, I've worked on kind of research where AI tool is developed and given to brokers, insurance brokers, in order to help them facilitate matchmaking between consumers and insurance firms. And so here, the goal of this AI is really related to what we were just talking about with helping steer consumers towards the best option for them. What the AI in insurance markets, what the AI does is it basically takes in kind of data from the individual, whether it's administrative data on their healthcare claims or whether it's supplied by the users themselves. So things like, what kind of plan do you want? What's your age? What kind of premium do you want to pay, etc. And so what we our specific study here basically studies the impact of deployment of this AI tool to brokers, and then having brokers basically act as an intermediary to help consumers use this AI tool. That's in some sense a way to think about it. And what we found is that in this specific case, which is a case study of one large broker basically selling to about 100,000 families per year, well, what we basically find is that this really helps make the recommendations. Actually, let me take a step back. There's kind of two things that happen. First, the tool or the use of the tool, the AI, basically significantly changes the choices that are being made. So that's kind of step one. That's just a fact. Step two is then, well, are these choices better? And we kind of show first that the choices much more closely follow the algorithm from the AI, which to us is a signal that the choices are better. But you could also argue that blindly following an AI tool is not always going to be the right thing. And so we also kind of provide a number of more subtle tests to show that, well, people are overruling the AI in certain cases where it's pretty clear they have a big benefit from doing so. And so that's kind of what we're looking at there. Now, the other example I want to talk about is not a study by me. It's a study by my colleague at UC Berkeley, who's named Ziad Obermeyer, who's in the School of Public Health. And what this study does is it looks at whether physicians in the emergency room are making mistakes in terms of how they perform testing of patients, and specifically in terms of how they read echocardiograms, which are called EKGs. And what EKGs do is they give kind of a sense of your pulse and your heart function, and it gives a pretty deep sense of this in order to, for example, help tell doctors, are you someone who's having a heart attack or likely to have a heart attack? And what Ziad and his co-authors show is basically that, using AI tools that are basically taking in data from the EKG and processing them, you can actually add value in terms of predicting heart attacks relative to what physicians are doing. Not in all cases, but in some cases. And so there you can think about the deployment of a tool potentially that takes in these EKGs, reads it with the AI, and then spits out something that's kind of an alert to physicians that tells them like, hey, you're not ordering these follow-up tests, but this is actually someone who, you should be thinking of as a stroke or heart attack risk. And so I don't know of kind of a tool like that actually existing or being deployed, but Ziad's research clearly shows that that could be valuable. And so those are two examples, one in the insurance space and one in the healthcare provision space. And, healthcare has, generally speaking, I'd say, been behind other sectors in the economy in terms of deployment of technology, not medical technology necessarily, but kind of management technology or consumer-facing technology. But I think that's changing. And there's certainly many, many, many startups working on these kinds of questions and issues. But even though it seems like there's been a lag, I'd say that these products are eventually coming. And I think a big part of the question, which we've hit on a little bit already, is, well, are you ultimately trying to deploy these technology tools to consumers or to firms or doctors on the supply side? And to me, I'd say that most studies so far seem to suggest that deployment either kind of to brokers or to doctors, that has a clear potential to be successful. To the regulator, if they want to do these default options, that can be kind of successful. But there aren't too many cases, I think, showing that kind of deployment of very sophisticated technology to consumers is necessarily helping them a lot. And I think it relates just to the fact that healthcare is such a complex area.
Mm-hmm. And I think as we start to project forward some of these changes, it finally brings me to the last question. So I'll stick to the first example you gave in terms of the application to insurance markets. Obviously, when we have an AI algorithm, well, AI isn't as susceptible to things like informational asymmetries. It can go crawl the web for a lot more information that humans can. It can be programmed to get around incentives issues with moral hazards, etc., that kind of are some of the foundational assumptions that we use in most economic theories when it comes to insurance markets. As these assumptions start to be violated, how will our study of these markets or our study of the theories that we use in terms of analyzing these markets with economics have to change going forward into the future?
Yeah, that's a very deep question. In some sense, there's a lot of different angles to it, and I think that one way to think about it is from an economic standpoint. I think to keep it a little simpler is to think of, well, in a typical economic model, often three kinds of actors. There's consumers, there's firms. In the healthcare sector, firms could also mean doctors, and there's a regulator who is often serving as some sort of intermediary or trying to kind of help steer things in the right direction in the market. And I guess in some sense, the answer to the question is, well, it can be thought of as AI can change behavior of all three of these actors in different ways. And how do we want to think about that? One interesting thing is that at least to the extent that you're deploying AI to help consumers make more informed decisions or quote unquote better decisions, you're actually in a lot of ways steering consumers closer to to the rational model that economics has been assuming for like 50 years, right? And so in a lot of ways, I think economists actually are very well set up to study the consumer-facing side, at least conceptually, as well as the firm side. In some sense, a lot of what AI does is it actually makes kind of all the actors in some sense more rational in the sense, specifically in the sense that it makes them act as if they're much more informed about everything that's going on. And it makes them more able to act on that information. Now, I think the cautionary aspect of this is that being closer to mainstream economics, I'd say that's what I said, it's certainly true in a conceptual sense. Now, in an empirical sense, in terms of kind of empirical work that's been done, that's been very important over the last 10 to 20 years, there's a lot of cautionary tales. And the reason is that a lot of these studies, for example, of healthcare markets or retirement savings or any other market, they've really been done in a context where there's behavioral consumers, there's firms who may not kind of have the bandwidth or the breadth to really act in such a sophisticated way. And what happens when you introduce these AI tools is it does have the potential to markedly change what's going on. And for example, if firms are taking more advantage of these tools than consumers, it could help firms either take advantage of consumers or profit from consumers more, or in theory, it could help firms create better products for consumers. And so I guess like in that sense, what I would say is conceptually, it actually might not change that much what economics has done for many years. But empirically, in terms of, which specific policy are we going to implement now, I think there it can really matter. And it can really matter because we may see behaviors that come about that are really different than what empirical studies of the last 15 years would have predicted in the absence of AI. And the reason is that you actually have people who are much more informed. I've done a study that looks at adverse selection and inertia. And so here, the way to think about this in a simple way in insurance markets is that, well, inertia is basically consumers are just making a lot of mistakes over time because they're not changing in a rational way. That's the way to think about it, not changing their insurance plan option. Adverse selection occurs when sicker consumers select into more comprehensive plans, and that can be bad for the market overall because then basically you have comprehensive insurance that it becomes really expensive, and then it's very difficult for anyone to choose that kind of option. And so the key insight of kind of the research I did here is that, well, if you help people become better informed, as an AI tool could do, or if you're a regulator and you default people into options that are kind of a better match for them, you're going to have people making better choices for themselves, but in a market level, you're going to facilitate this adverse selection by quite a bit. The reason is that if you think of consumers as choosing randomly because they have poor information, that's basically saying there's no adverse selection because you aren't really having sicker people matched in a certain way or healthy consumers matched in a certain way because they don't know what they're doing, right? If you have an AI algorithm and it's helping these people match specifically in a very, very acute way, then you're getting rid of this problem of consumers making good choices for themselves, but you're introducing this extra problem where you're saying, wow, this market is going to have a lot of problems because of this adverse selection issue. And so then there's nothing new about that from a conceptual economic standpoint. But as a regulator, you had this environment where you didn't have to be that worried about adverse selection for, and empirical papers show this. And now you have to be super worried, and you have to implement all of these complementary policies to help with that. That's just one example.
Yeah, I think it's really amazing to hear about things that real economists are thinking about right now, because you don't get to hear about this in any, classical economics course. So I really wanted to thank you for talking about all of this insight about the state of the healthcare markets when it comes to economics right now, but also all of the really, really amazing ways that it's changing, both for the better in the West when it comes to what we'll be doing later. So thank you for taking the time.
Thank you very much. And, it's been fun to come on.